following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. This series is supported by independent educational grants from Astellas, AstraZeneca, Janssen Biotech Inc., administered by Janssen Scientific Affairs, LLC, Lantheus Medical Imaging, Merck Co. Inc., Pfizer Inc., and Sanofi Genzyme.
Good afternoon. My name is Raman, and I'm professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to welcome you to another one of our AUA University podcasts, with this podcast specifically being titled Novel Imaging for Genitourinary Cancers. My guest today is Dr. Marc Bjurlin. Dr. Bjurlin is Associate Professor of Urology and Director of Clinical Trials at the University of North Carolina in Chapel Hill. Marc, first of all, thank you so much really for joining and obviously in advance for your time and expertise on this podcast.
Absolutely. A pleasure to be here, and thank you for the invitation.
No, that's great. And, for our listeners, Dr. Bjurlin actually teaches one of our courses at the annual meeting in the whole space of nuclear medicine-based imaging. And so I would certainly tell you that for any of you that are interested, he and his team will be having a course at the AUA annual meeting in May of 2023. This podcast is structured a little bit like a potpourri. So I'm going to be talking to Dr. Bjurlin about some of the different diseases that we treat: prostate cancer, kidney cancer, urothelial cancer. And we'll talk a little bit about, what type of PET imaging is available, as well as clinical trials or perhaps some of the data underlying the use. So, Marc, if you're good, maybe we'll just start off with prostate cancer, if that's okay with you, and maybe I'll just sort of start picking your brain and then have you sort of weigh in on some of the concepts. Does that sound reasonable?
Absolutely. Love it.
So maybe, when we talk about PET-based imaging for prostate cancer, maybe even before we look at the actual sort of, what scenarios do we use it in? Can you give us a little bit of a perspective of, we've kind of gone through this evolution for a good amount of time. We really didn't have very good PET-based imaging for prostate cancer. And then obviously we've now had this evolution over a number of years, certainly with fluciclovine, and now most recently with PSMA-based, and even the different types of PSMA-based PET imaging. Maybe just walk us through the evolution and realistically now in clinical practice, what would we be using and seeing in day-to-day use?
Yeah, I think that really sets the stage. Historically, in men that have a disease risk stratification that may be at risk for either locally advanced or metastatic prostate cancer, we conventionally get a contrast enhanced CAT scan to look at any, regional or distant metastases in combination with a bone scan. These types of imaging tests are readily available. They're relatively cheap and easily accessible. But, through years of research, we've found out that there can be some false negatives, some false positive, and some indeterminate, assessments using these tools. And as a result, PET imaging has moved into this kind of disease stage. And when we talk about PET imaging, just to kind of clarify to some of the listeners, that typically a PET imaging modality is acquired in combination with a CT scan. So the PET imaging uses a radiopharmaceutical agent that binds to or is taken up in some type of target tissue of interest. And this really looks at function, and then it's overlaid on top of a CAT scan that gives us anatomical detail. And as you mentioned, fluciclovine, the Axiom scan came up, maybe almost 10 years ago, and we thought it was going to be novel and offer good performance characteristics to stage men with prostate cancer. But we found out it had several limitations. And as a result, there's been further work into other radio tracers. And lo and behold, PSMA, prostate-specific membrane antigen, has come to the forefront of this. And now there's been some exciting developments in terms of clinical trials and FDA approval in this space.
No, that's great. No, I think you set the stage really well. And maybe even before perhaps we talk about maybe the clinical scenarios, maybe just with PSMA-based PET imaging, talk to us a little bit about, maybe the gallium-based imaging and why that was sort of really wasn't widely adopted, and maybe the differences with Polarify, for example, which obviously we are using more, and what most of us will see in practice. Maybe I'll start with that, and then we'll go through some of the clinical scenarios of use.
Yeah, so a number of kind of imaging agents have been used in the CAT scanning space, and there's been a whole lot of heterogeneity in terms of trying to determine what is a positive finding and what is a negative finding to stage men with prostate cancer in terms of lymph node morphology, fatty hilum sizes, and the criteria are kind of a little bit gray, as well as the interpretation. And as a result, you can imagine that a lot of the data we get from these imaging tests are a little bit indeterminate, which kind of push towards finding a better radio tracer or a better imaging modality.
So what, when we specifically look at sort of PSMA-based imaging, what are some of the clinical scenarios that we should be using these or considering use in practice?
Yeah, great question. So there was a really kind of unique collaborative that came out in the last couple of years, which was a PSMA appropriate use criteria article that had a group of multidisciplinary panel specialists in prostate cancer, including the Society of Nuclear Medicine, Molecular Imaging, representatives from the American College of Nuclear Medicine, American College of Physicians, ASCO representatives were on this paper. AUA had a strong representation in this paper, as well as Australian, New Zealand, and European nuclear medicine specialists. And what they essentially did in this article is came up with 11 clinical scenarios that documented the appropriateness of using PSMA in different clinical scenarios. And in order to score each clinical scenario, they gave a scoring system of 1 to 9, 1 being the least appropriate and 9 being the most appropriate. And then essentially there were 5 clinical scenarios that were scored 7 through 9, which is considered appropriate use. So happy to touch base on some of those scenarios if okay by you.
Yeah, so why don't we talk about some of those? Having you sort of set the stage very nicely for what is how you define appropriate use. So what are some of these scenarios that you mentioned?
So the group kind of quantified them into initial staging, biochemical recurrence, and then some castration resistant stages. But in terms of initial staging, the group came up with 2 appropriate scenarios, and this is for men with newly diagnosed prostate cancer. And the first scenario they define is the appropriate use of PSMA is for newly diagnosed, unfavorable, intermediate, high risk, and very high risk prostate cancer. And they gave that a score of 8. So you're saying if you see one of these men in your clinic, it would be appropriate to then get a PSMA PET to further stage their workup. And there has been some clinical trial data in this space supporting this use, and that PSMA PET has been shown to be more accurate than conventional imaging, especially in these high-risk men. It results in fewer equivocal imaging tests, lower radiation exposure, and ultimately greater impact on treatment. There was one other clinical scenario in initial staging index patient that this group has mentioned, and that is newly diagnosed unfavorable intermediate high risk or very high risk cancer with a negative or an equivocal oligometastatic workup on conventional imaging, meaning that someone may have nodes, we're not quite sure if they're positive, not quite sure if they're negative, and this would be appropriate man to get a PSMA PET on. And the clinical data does support that in these men with possible oligometastatic disease, that this PSMA PET may actually shift them over to polymetastatic disease. And as a result, you can imagine their clinical management would significantly change if that's the case.
So certainly, as you alluded to, we now have several indications in the newly diagnosed setting, and you outlined, I think, very nicely those different clinical scenarios based upon the risk strata for the patient, or, as you mentioned, prior imaging that may suggest the presence of metastatic disease. What about scenarios after primary therapy, whether that be surgery or radiotherapy?
Yeah, so the group gave two appropriate scores in the biochemically recurrent scenario. The first was in men who have a PSA rise or a persistent PSA from an undetectable level after radical prostatectomy. And this got a score of 9, which again is an appropriate use for PSMA PET imaging. And there's kind of this $1 million question as to what level PSA should you then get the PSMA PET scan. And the group actually was careful in their wording, and that even though there was debate about whether a PSA threshold should be used to determine at which time the men should undergo a PSMA PET, it was decided that there should be no defined level. So essentially the take-home message is don't wait until you think the PSMA is going to be positive. When you see that PSA start trending up, it would be appropriate to go ahead and get it. I was going to say,
Marc, let me just ask you practically, just in that setting, in your practice, let's say you do a radical prostatectomy on somebody, and I don't know, a year or two later, their PSA is 0.1, 0.15, 0.2. Obviously, the higher this number goes, the higher the likelihood that your PET-based imaging will be reliable. That being said, the higher the number goes, the less potentially successful your salvage therapies such as radiotherapy are. So in your own practice, even though the panel didn't pick a certain threshold, is there a certain value that you sort of use in your practice as your sort of threshold for ordering, or does it really just vary patient to patient? I guess I would worry about ordering a test so soon that it doesn't give me a yield because I've picked up the disease too early in the process to see it on imaging. Your thoughts on that sort of thought process?
Yeah, I struggle with the exact same scenario in clinical practice. And then the other kind of caveat, unfortunately, we have to think like this, but if you get it too early, is it still available, through the insurance authorization to get it subsequent 6 months later as you need? So typically in my practice, I will try to trend at least a couple PSAs to say, all right, it truly looks like this is an increase and a significant increase. And at that time, it's really kind of clinical judgment, and I'm going to go ahead and get it. But I typically, after learning more about this and reading in detail, I tend to err on the earlier side than waiting until it's significantly higher.
Great. And now, what about after radiotherapy? What are sort of the thresholds to use at that juncture?
So similar kind of definitions the group gave, and that the clinical use scenario is appropriate when there is a PSA rise above the nadir after definitive radiotherapy. And again, the group avoided giving a threshold at which point that is the case. But again, clinical judgment when the PSA starts to rise after a man who's been treated with radiotherapy, that it would be appropriate to get a PSMA PET.
And then maybe the final scenario, I think you alluded to it briefly, was the setting of castrate-resistant prostate cancer. And are these, M0 patients who have sort of normal conventional imaging, or are we talking about maybe M1 patients to better define the burden of their disease that may not be wholly captured by conventional imaging.
Yeah, very insightful. The authors did specify specifically that it's appropriate for non-metastatic castrate-resistant men who have M0 on conventional imaging, but there is a well-cited study that when you do get a PSMA PET on a man with what you think is non-metastatic castrate-resistant prostate cancer, about half the time the PSMA PET will find M1 disease, which you can imagine then would significantly change our management strategy. But that clinical scenario was also given a appropriate use score to get a PSMA PET for that man.
And then maybe just sort of final question in this space, and then any other thoughts you have is, it seems like this PSMA-based PET imaging is sort of setting the stage for this whole concept of theranostics, that we're identifying these lesions and therefore perhaps then can deliver more targeted, radiotherapy with lutetium or whatever agent of choice. Do you think that's, I know some early work is done there. Do you think we're sort of on the cusp of that being integrated into clinical practice more? What are your thoughts on that?
Yeah, I think the theranostics is definitely coming down the pipeline. There's been some interesting, promising studies that have been positive in that space. And I really think that kind of imaging-directed, molecular-directed treatment is going to be our next step in managing patients with metastatic prostate cancer.
Great. I was going to maybe change our focus, unless you had anything else. I was going to maybe change our focus towards maybe kidney and just talk about that. Does that sound okay from your end?
Yep, let's do it.
So, talk to us a little bit about with regards to kidney pathology and sort of renal masses, the sestamibi scan. What is it? How does it work? And how does it fit into clinical practice? How do we use it, or how are we supposed to use it? And what does it differentiate?
Yeah, so sestamibi is actually a lipophilic cationic mitochondrial imaging agent that is previously widespread used in the myocardial and parathyroid imaging space. And how it works is that the technetium labeled sestamibi accumulates in cells with really high mitochondrial content and low what's called multi-drug resistant pump expression. So different histologies of kidney masses have either high mitochondrial expression and low drug resistance pump expression, or vice versa. And as a result, the uptake of this tracer can then help discriminate between a benign oncocytoma or for example, clear cell renal cell carcinoma.
And so is that the major distinguishing point is really potentially the identification of oncocytomas or oncocytic lesions? Is that correct?
Yeah, so there's a significant increase in mitochondrial and a decrease in that multi-drug resistant pump expression, which are classically characteristic of renal oncocytomas. And then on the flip side, clear cell renal cell carcinomas have the opposite. They're essentially devoid of mitochondrial and have a very high multi-drug resistant pump expression. So you can hopefully separate out oncocytomas from a more aggressive renal cell carcinoma based on a sestamibi scan. And then there's varying amounts of mitochondria, but a relatively high multi-drug resistant activity in other renal cell carcinoma subtypes. So the goal is really to discern benign tumors from malignant tumors based on this imaging test.
And so based on what you're saying, so it seems like the test has the ability to discriminate, as you alluded to, maybe more biologically aggressive kidney cancer like clear cell subtype versus oncocytoma. How does this sort of that spread between an oncocytoma and maybe a chromophobe renal cell carcinoma? Things that I think about maybe are first cousins of each other. More indolent kidney cancers, and maybe histologically fairly closely related. How does this test work with maybe distinguishing or differentiating, or can it, or is that one of the weaknesses of the test?
Yeah, I definitely think that is one of kind of that indeterminate spaces, the limitations of this imaging. some of the original studies done by Mike Gorn's group, looked at 50 patients with solitary renal masses who all got a cystectomy scan prior to their surgery, and they had a sensitivity of about 87.5%, specificity about 95% for the diagnosis of renal oncocytomas, but that also included those tumors you just mentioned, hybrid oncocytic tumors, chromophobe tumors, and there were a couple of false positives. 2 out of the 50 did have eosinophilic variants of chromophobe renal cell carcinoma. So by no means is it a perfect imaging test, and some of those less aggressive ones may actually come up as a false positive.
And maybe just to finish the thought on this, maybe 2 questions. First is, what is the body of evidence or the literature? Is this fairly robust that these cystectomy scans are used and have been published on in the literature? Where are we sort of in this whole sort of adoption, if you want to talk about adoption curves, right? Are we on our way, or is this more in the early phases based upon the existing data?
Yeah, I think we are in the early adopters for this imaging test, mainly academic centers. The first study I cited was 50 patients. It's been since externally validated on a much larger cohort, but I must express, in my own opinion, I've had some challenges in repeating some of the results that have been published. I've spoken to some of the expert groups on, hey, I'm not quite being able to get the specificity and sensitivity you are. What pointers can you give me? And I think they have hinted a lot of it is in the nuclear medicine interpretation of the imaging. And there's a bit of a learning curve in that. And maybe perhaps when it's more kind of ubiquitously understood in the imaging modality, that perhaps it'll move along in the adoption curve a little bit more.
It's interesting when you say that, because I feel like we see this in the life cycle of many of our imaging studies that we use. You think about maybe the earlier days of prostate cancer and MRI and PIRADS assessments, and some of the analyses that when you're at centers that have a very focused experience, obviously the performance characteristics and the diagnostic accuracy are greater than when you see it out in the general population. And you wonder if a lot of this is similar sort of learning curve, interpretation of studies, and getting enough volume that your interpretations are consistent. And it seems like this is sort of similar in that same thread.
Yeah, I would say I agree with that entirely, that there is going to be kind of an experience adoption to this imaging modality.
So we talked a little bit about, maybe the benign tumors of the kidney, oncocytoma, the more indolent lesions. What sort of nuclear medicine-based imaging do we have when we're looking at maybe the more aggressive kinds of kidney cancer, the clear cell variants, those that, really do have a significant potential for metastasis, both, at time of presentation or further down the line? What tools do we have in that space?
Yeah, so the timing of this podcast is quite serendipitous, because there is this humanized monoclonal antibody that binds to the carbonic anhydrase 9 called girentuximab. And it's been studied, and actually this week data from their phase 3 trial was actually released. But essentially, under normal physiologic conditions, this CA9 is upregulated in hypoxic conditions, and it serves to catalyze the reversible hydration of carbon dioxide. And as a result, the CA9 is overexpressed in 95% of clear cell renal cell carcinomas. So the goal of this agent is really to identify those aggressive clear cell renal cell carcinomas. And girentuximab, this monoclonal antibody, can be labeled with a different number of radionucleotides. Iodine has been looked at, iodine 124 labeled to girentuximab. PET scan, there's initial data on 26 patients that came out with a quite high sensitivity of 94%. And then there was some work that kind of validated that finding in the REDECT trial. And after this trial came out, and said, you know what, this seems to be working quite well to identify renal cell carcinoma, that there is thoughts about taking this to the FDA to get approval. And the FDA said, well, we need a larger study. So a second multi-center study of 30 different sites worldwide, internationally, looked at girentuximab, and actually they was radio labeled to zirconium rather than iodine, because there's some thought that zirconium labeled girentuximab has higher uptake and higher retention, and therefore more sensitive to renal cell carcinoma. But yeah, just this week, that phase 3 trial released their data, and they delivered on several endpoints. So they found an 86% sensitivity and an 87% specificity, 93% positive predictive value of identifying clear cell renal cell carcinoma using this PET imaging. So very promising data in this space. And again, it's probably on the early adoption curve, but zirconium labeled girentuximab is definitely coming down the pipeline.
And those performance characteristics that you just talked about, was that performance characteristics with respect to the primary lesion, or was this for sites of disease outside of the kidney?
Yeah, so this is identifying the histology subtype of the primary lesion.
So it seems like we now may have a second tool that identifies almost the other end of the spectrum, right? The cestamibes we've been talking about thus far is the indolent oncocytomas, or maybe even that maybe the hybrid oncocytoma chromophobe. And now you've got something which really identifies, I think the biologic aggressive actor here. And one wonders over time how the concept of renal mass biopsy has been advocated in many scenarios. But obviously, although it's overall a safe procedure, there is some risk, right? There is always some risk. And you wonder, as we get more of these tools, how much these refined imaging may potentially obviate, if the performance characteristics are good enough, maybe obviate some of these biopsy procedures down the line.
Yeah, definitely. This would be kind of next level non-invasiveness to characterize the type of renal mass that patients may have. We should probably even mention some limitations of it, just because we're on the topic, that, for the girentuximab, it floats around in the bloodstream for quite a while. So patients often have to get it injected 5 to 7 days in advance of their imaging test. So keep that in mind, while the cestamibes can be done 75 minutes after the injection. So in an ideal world, you could probably consider doing dual labeled radio tracer, where you can put both of them on there. It's just that you'd have to work through the timing on after the radio tracer is given, when can you actually scan a patient to get the useful information you want. Sure.
So let's pivot now, and let's sort of maybe finish our last disease space that we work on a lot as urologic clinicians, which is urothelial cancer. And maybe first talk to us a little bit about what types of radio tracer do we use for urothelial cancer? And then maybe we'll start with that, and then talk a little bit about performance characteristics, and then what clinical scenario. So what do we use here for urothelial cancer?
Yeah, so conventionally, the radio tracer is FDG, which is good at picking up distant metastatic disease, and it's good at identifying some lymph nodes. But one of the main concerns of using an FDG radio tracer is that it pools in the urinary tract system, meaning that the collecting system, ureters, and the bladder all light up super bright, super avid on the PET scan. And as a result, it can't be used reliably to stage the primary disease. You can't determine if someone has T2, T3 disease, but it may be an adjunct in combination with CAT scanning to identify lymph nodes or distant disease. There is some work done in the space of choline radio tracers. One of the drawbacks of a choline radio tracer, however, is its very short half-life, meaning that if you're going to use it, you have to have essentially a cyclotron, a device to make that radio tracer on your site, because it can't be made and then shipped across country, because it simply, the half-life is too short. But those are kind of the main two in study, both with some limitations. And as a result, they are not yet endorsed in national guidelines as the imaging modality for bladder cancer staging.
So just to dovetail on that point, so what would be the clinical scenarios, ideally, that these may be used in? Primary, like at diagnosis, or in a surveillance setting, or to monitor sort of treatment to systemic therapies? Where would we use this for urothelial cancer?
Yeah, I think there's probably a few that's most useful. The NCCN and the American College of Radiology give specific guidelines on muscle invasive and metastatic bladder cancer pre-treatment. So those patients who you think may have at least T2 disease, or if you think it's going to change their management to T3 disease, this would be a reasonable test to get. The American College of Radiology isn't quite as stringent in their recommendations. It says it may improve some sensitivity of nodal detection. There is some increasing evidence that it may outperform contrasted CT scan, but a lot of maybes. And then the second is really post-treatment surveillance, meaning that in men who have already, or I shouldn't say men, in our patients in general who have already been treated, you can look for recurrent disease or anything that's equivocal on conventional imaging after treatment. And then probably the evolving space is if you can identify patients during neoadjuvant chemotherapy who would benefit from completing chemotherapy versus those that you can identify as an early non-responder and say, hey, you've gotten 2 cycles of chemotherapy. It doesn't appear that it's getting us to where we should be. Skip the other 2 cycles, go straight to surgery. Or if you're getting a great response, complete the chemotherapy and then move on to surgery. All still to be determined, but I think treatment response is really going to be the next space that radiotracers are going to help manage bladder cancer.
And what kind of data do we have just on performance characteristics compared to conventional imaging with CT or MRI? Is there any data yet, or is that still fairly, does that need to mature?
It's rather ironic that I think it's evolving. And when I say that is, in preparation for this podcast, I was actually doing a little bit of reading to just refresh my memory. And there was a very good review paper that came out in a urology journal on this exact topic. And there was a very good review paper out in a nuclear medicine journal on this topic. This just is essentially comparing FDG PET scans with contrasted CAT scans. Which is better? Which should we be doing? And the urology journal said no improved performance over contrasted CAT scan for the NucMed PET scan. And the NucMed journal said, by all means, a FDG PET outperforms contrast imaging. And this was published within weeks of each other using the same data. So I think really the take-home message is that there's a number of limitations so far in this imaging space, including the heterogeneity of the methods used for the studies, the study design, the inclusion criteria, the exclusion criteria, the administration of neoadjuvant chemo, the injection acquisition time to the PET, whether the abnormality on PET imaging is confirmed by pathologic biopsy. So a lot of limitations so far in the literature, but hopefully further study groups will kind of push the understanding of this PET agent, and hopefully it'll improve the care of our bladder cancer patients.
And then maybe the last question I'd have for you in this urothelial space is, as you well know, immune checkpoint inhibition has really moved to the forefront with a lot of our systemic therapies, and a lot of these are predicated on expression of whether it's PD-1, PD-L1, but expression profiles on these tumors, and that may be able to help us gauge response. Do we have any tools that may be there to help us sort of assess this?
Yeah, there are a couple of studies in their infancy looking at zirconium-labeled PD-L1 radio tracers to look at specific response in disease processes that are treated with PD-L1 inhibitors. The data is very immature, but it is very promising. And I would suspect that we'll be definitely seeing a lot more of that type of investigations coming down the pipeline in this disease space.
Well, that's great. Well, Marc, I really want to thank you. You sort of took us in a very cogent manner through sort of all the different diseases. And I think it was really an outstanding summary of sort of what we have available and obviously some of the strengths and weaknesses across these settings. So, Marc, first of all, thank you so much for taking some time today to do this podcast.
Pleasure. It's been a great time. Thank you so much again for the invitation.
And for our listeners, thank you again for joining us. If you would like any other information, please visit us at auanet.org/university. And as I mentioned, Dr. Bjurlin does have an entire course at the annual meeting. And please, I encourage you, if any of this content you found to be interesting, you'll get to see him live and in person in Chicago, and you can pick his brain actively at that point. Marc, have a great day. Thanks so much. Appreciate it.
All right. Thank you again.